So today I wanted to talk about something that many people are experiencing, and it's been a phenomenon that I remember noticing was surfacing during the pandemic, during the lockdowns, because people were on Zoom a lot, and then there was this term called Zoom dysphoria. Well, it didn't go away even after the lockdowns were ended, right? Um, So it is something that is still being experienced because of the rise in telework, as well as just the increased use of digital media. So it's become more commonly talked about, but it's still not fully understood. And it is this situation that has really become more concerning, in my opinion, in the last couple of years. And it's why social media filters can distort self-image so powerfully, and what trauma-informed therapy may help with in recovery. So I think it was about 2 years ago now that there was the bold glamour filter on TikTok, where people were making videos of what they looked like before they turned the filter on. And there were a few that got really popular, and they said, this filter like gave me filler, right? It was so difficult to discern that someone was having a filter because it looks so realistic. Anyway, but that was an example of just how these filters can really, they're popular, but there's sort of like there's a bit of a side effect. Okay, so this conversation is not about blaming social media, and it's not about telling anyone to stop using filters. I think that they can be fun. It's about understanding what happens psychologically and neurologically when repeated idealized images of ourselves begin to feel more real and more desired than our actual bodies. Um, so, and importantly, this is an educational discussion, not therapy, not diagnosis, and not treatment advice. It's really bringing light to an issue that is more serious than maybe people might realize or might think. So I'll be referencing psychological research, guidance from organizations like the American Psychological Association, and what peer-reviewed studies currently show about trauma-informed therapies such as EMDR and Brainspotting, including their limits, not just their potential. So why do filters affect self-esteem? Well, from a psychological perspective, filters don't just change how we look, they change how the brain learns to recognize the self. The American Psychological Association has long documented how social comparison, repeated visual exposure, and idealized body standards are associated with an increased risk of body dissatisfaction, shame, anxiety, depressive symptoms. So filters intensify these processes because they create a consistent, emotionally reinforced image of the self that the nervous system begins to encode. Now, this is not vanity, it's learning. So the brain is excellent at learning patterns, especially visual patterns tied to emotion. When someone repeatedly sees a filtered version of themselves with smoother skin, altered proportions, subtly optimized facial symmetry, the brain can begin to register the unfiltered body as wrong, unsafe, or deficient, even if the person consciously knows the filter is not real. This is where self-image distress can become felt, not just thought. So self-image distress is often somatic. So one of the most important insights from trauma psychology is this. Distress is not stored only in thoughts. It is also stored in the nervous system. The APA and trauma researchers consistently describe how shame, threat, and identity-based distress often show up as visceral reactions, body tension, avoidance of mirrors or cameras, spikes of anxiety when seeing one's own image. This matters because self-image disturbance is often not purely cognitive. People may know, hey, I don't really look like that, but still feel, I'm not okay as I am. That gap between knowledge and felt experience is where trauma-informed therapies come into the conversation. Not as cures, but as tools for processing distress that is embodied, image-based, and emotionally loaded. So what does trauma-informed actually mean? Well, Before talking about specific therapies, it's important to clarify language. Trauma-informed does not mean assuming everyone is traumatized, pathologizing normal distress, or claiming one method works for everyone. According to the APA, trauma-informed care means recognizing how distress affects the nervous system, prioritizing safety and consent, understanding that symptoms often make sense given someone's experiences. When we apply this lens to filter-related self-image distress, the question becomes, how can therapy help the nervous system reintegrate self-perception rather than fight it cognitively? And that's where EMDR and brainspotting are often discussed, carefully and within scope. So, what does the research to date say about EMDR? So, EMDR, eye movement desensitization and reprocessing, has one of the strongest research bases among trauma-informed therapies, or trauma-focused therapy, sorry. It is recognized by the American Psychological Association, the World Health Organization, and multiple international clinical guidelines. Peer-reviewed research, including randomized controlled trials and meta-analyses, consistently shows that EMDR can be effective in reducing PTSD symptoms, trauma-related anxiety, shame and negative self-beliefs, emotionally charged mental images. This is important for self-image recovery because negative self-image is often maintained by emotionally charged internal images, not just verbal thoughts. Research suggests EMDR may help by reducing the emotional intensity attached to these distressing images, allowing more adaptive information to integrate, supporting nervous system regulation over time. However, and this matters, EMDR is not studied specifically as a treatment for this kind of distortions that are results from social media exposure, or basically it's not a treatment for Zoom or Snapchat dysphoria. That's not a clinical term. It's not in the DSM, the Diagnostic Standard Manual. Sorry if I've got it wrong, please correct me. But that's not an actual thing. So like major depressive disorder, that's an actual diagnostic name, but Snapchat or Zoom dysphoria is not. But I'm using it sort of in the non-clinical sense here. So the evidence supports EMDR for trauma-related distress broadly, which may include body-based shame or identity distress when those are part of a larger clinical picture. So that is a crucial distinction for managing expectations. And now what does the research say about brainspotting? Well, brainspotting is newer than EMDR and has a similar but growing research base. So brainspotting does not yet have evidence-based status. If I am wrong, someone tell me in the comments. And peer-reviewed studies so far include pilot studies within subject designs and comparisons with EMDR and non-clinical or mixed samples. So these studies suggest that brain spotting may help reduce subjective distress, emotional activation, trauma-related symptoms, particularly when distress is somatically felt, like in the body, visually triggered, difficult to articulate cognitively, hard to find the words. However, it's important to be clear and ethical. Brainspotting does not yet have the same level of large-scale randomized controlled trials or guideline endorsements as EMDR. Most professional discussions describe brainspotting as promising, adjunctive, and used alongside other therapeutic frameworks, not as a standalone solution. Responsible clinicians present it this way, and so should public education. So how do these therapies fit potentially into recovery? Well, based on current evidence, the most accurate way to frame EMDR and brainspotting is this. They may be part of a recovery journey when self-image distress is emotionally charged, shame is felt in the body, and visual self-perception triggers identity, anxiety or avoidance. However, they are not quick fixes. They are not cosmetic solutions or appropriate for everyone. Research and clinical consensus emphasize that effective recovery usually involves careful assessment by a licensed clinician working within their scope and competence, and integration with broader therapeutic work. And this may include body image work, attachment-informed therapy, developing healthy emotional regulation skills, and other evidence-based cognitive approaches. So trauma-informed therapies are tools, not answers, and the data so far supports that cautious, integrated view. All right, so where to get credible help? So if self-image distress related to social media or the impact of using filters is affecting your well-being, the most important step is working with a licensed mental health professional in your state of residence. So look for clinicians who hold a valid license, such as a licensed marriage and family therapist, licensed clinical social worker, licensed professional clinical counselor, licensed psychologist, etc. And look for clinicians that are trained in evidence-based or trauma-informed care and can explain their approach transparently. Psychology Today has a feature on the website where you can search for a therapist and you can sort the data in the directory per your state of residence as well as your insurance. So if EMDR or Brainspotting is mentioned, it's appropriate to ask in consultation with a potential licensed therapist, if you are seeking care, how they integrate these methods, what the evidence supports, and how progress is going to be evaluated throughout treatment. Because the ethical care always includes informed consent and realistic expectations. All right, so this video is for educational and informational purposes only. It is not therapy, diagnosis, or mental health treatment, and it is not a substitute for working with a licensed mental health professional. It has discussed psychological research and trauma-informed approaches, including EMDR and Brainspotting, as they are used by licensed clinicians, not as self-help techniques and not as standalone solutions. If you are seeking support, please consult with a licensed mental health professional who is legally authorized to practice in your state of residence.